Hello and welcome to today's Kauai Health Community webinar. My name is Deborah Volleson and I am joined today by our CEO, Gary Herbst. And thank you. We appreciate you coming on a Tuesday. Today is Tuesday, December 10th, a few weeks away from the end of the year, which 2024 has flown by, it
Oh,
seems.
yes.
And so we're getting ready to ring in 2025.
Christmas, 2 weeks
It's 2
from
weeks.
tomorrow.
Oh, yeah. Are you ready?
No.
Well, thank you, Gary, for taking the time to sit down with us and just answer some questions that people have submitted. We're going to cover funding today. We're going to cover our emergency department, some local physicians, and OBGYN care. So we are going to jump right into the questions. I had the privilege of being at the foundation, the Kauai Health Foundation board meeting yesterday. And when you started off by saying, I'm only sharing good news, and then you started talking about funding, and I thought this would be a great place to talk about funding. So would you share with us some of that great news that you told the
Yeah,
foundation board
absolutely.
members?
And from a technical standpoint, David, which camera am I looking into? The fixed one? Okay, gotcha. All right. You knew that already.
No.
But, unfortunately, the poor Kauai Health Hospital Foundation board over the last 4 years, oftentimes what I've been sharing with them, particularly with respect to the financial challenges that Kauai Health and virtually every hospital across the nation has faced over the last 4 years during COVID and really post-pandemic as well. I don't always have a lot of good news to share with them. So yesterday I said, in keeping with the holiday spirit and the celebratory nature of this time of year, I thought I would share nothing but positive news. So thank you for teeing that up. I think I've been talking about this probably for the last several years, but if you don't recall, let me refresh your memory. That for the first time, obviously because the first time that we lived through a pandemic like COVID, the federal government, through the Federal Emergency Management Agency, or FEMA, which is quite accustomed to working through natural disasters like hurricanes and floods and wildfires and so forth. Because the president declared that COVID was a national emergency, essentially a disaster, it kind of fell into that same category as those natural disasters. So hospitals have been permitted to file a FEMA claim with the agency demonstrating the cost, the incremental cost, the above and beyond cost that hospitals incurred and were uncompensated for those additional costs as they addressed the pandemic. And you've heard from me extensively our dependency on contract labor, reaching out to all the nurse traveler agencies. At one time, we had close to 250 nurse travelers that were at the bedside taking care of patients, paying anywhere from $200 to $300 an hour for those contract nurses, when generally an employed nurse earns about $50 an hour. So to pay sometimes, 7, 8 times that, we literally spent well over $100 million in contract labor, but also supplies and personal protective equipment and so forth. So we were permitted to make a claim to FEMA seeking funding or reimbursement for these disaster-related costs that we incurred. Since FEMA has never dealt with anything like this before, again, they're quite experienced in measuring the cost associated with a hurricane or a wildfire. They really struggled to understand the costs of this particular disaster. So Melinda Tupper, our Chief Financial Officer, and bless her, I kind of tease her for her dogged perseverance, because she never gave up, and I think a lot of lesser CFOs might have given up because it was unbelievable what she had to go through. Literally, patient by patient, and COVID had to be the primary reason why that patient was in the hospital. So they couldn't be in the hospital because they had a heart attack, but they also tested positive for COVID, which would generally result in a higher cost of taking care of that patient. So not only are we taking care of their heart attack, but we're also having to treat their respiratory failure, and oftentimes leading to intubation or on BiPAP or some type, and they generally stayed longer too. So, but we had to follow FEMA's guidance, and so they had to be COVID as their primary reason for being in the hospital, and then we literally had to attach hour by hour what we paid for that nurse traveler to take care of that COVID patient in the hospital. And we cared for thousands and thousands and thousands of COVID patients over the pandemic. But we were able to demonstrate that to FEMA. And so over the last couple of years, it's been going through a very extensive review process. There's many, many hurdles that we have to clear at both the federal and at the state level. So I'm delighted to report, as I did to the Foundation Board yesterday, that last Monday, December 2nd, we received word from the Governor's Office of Emergency Services, the Cal OES, that we had been formally and finally approved for two of our largest claims that amount to $47 million. They have now been designated as obligated. And once they are classified as obligated, then they become a formal liability of the federal government, recorded as a liability on the federal government's books. There's no further review or approval that needs to be done at this time. We are thinking that we likely will receive these funds in January or February. I don't know if it'll be a big check or a wire transfer. But $47 million, it is a one-time payment to Cahuilla and other hospitals. I talked to Craig Castro, who is the soon-to-be retiring CEO at Community Regional Medical Center, or Community Health Centers in Fresno. They have a $100 million FEMA claim outstanding right now. So I don't know if they're hot on our tail in terms of them also receiving obligation designation. But the 47.7 million to be exact. But then Melinda informs me that there might be another close to 3 million in smaller applications that could follow on the heels of this. So that would be 50 million in total. It's all considered income to Cahuilla. Definitely it was not budgeted because there's been a high degree of uncertainty over the last couple of years, and even putting our budget together for the current year, we were very cautious, and were as tempting as it was because we were getting lots of affirmative signs that we were going to be approved. We still decided we're not going to recognize it until we see the whites of its eyes, so to speak. So this will be recorded as income in December. It will be like an accounts receivable on our balance sheet, and then when we actually receive the cash in January or February. So we want to discipline ourselves, as you all know. During the low point of COVID, our liquidity, our number of days cash on hand, which is how much do you have in cash reserves that can cover your daily operating expenses, we were all the way down to 62 days, well below the minimum requirement of our bondholders, and technically we're no longer in compliance with our bond covenants. So it would be tempting to go out and spend this money. You certainly would not want to spend it on something that obligates us to now a recurring expense, because this is again one time. But we are seriously looking at potentially fully funding our 401k plan this year. We only budgeted to fund half of it, so the board will evaluate that. We'll talk a little bit about elevators. Included in our budget for this year is to replace 3 of our elevators in the Minnow King Wing. They're about 1.5 million each. But with this additional FEMA funds, is it possible for us to do even more replacement of those elevators? So that will be also something that we consider.
Well, and let's remind everybody, how much does it cost to run our hospital for one day?
Roughly 2.5 million a day.
Right. So if you look at that in that, okay, that's 25
we
days.
burn through it
Yes,
pretty quickly.
You'd burn through it really. And clarify the 60-some days cash on hand. That does not mean we're 60-some days away from closing.
No,
it means
no. It's actually, I'll say it's an accounting term, but it's really more of a banking term, a finance term. Generally, every hospital that borrows money from a bank or issues bonds that are bought by investors require that the hospital be able to demonstrate on an ongoing basis its fiscal viability. Because certainly if you're a bondholder and you've got a 30-year bond in your hands or even a 10-year bond, you want to know that that hospital is financially viable and has the ability to fully repay that principal and the interest and so forth. And so two of the most important measures that creditors look at, one being that number of days cash on hand. And they love to see businesses have lots of cash, which you've heard me say is ironic that companies that really need cash and therefore need to borrow the money have a really hard time borrowing money. Banks like to lend to companies that have lots of money, which seems kind of counterintuitive, but nevertheless, so that day's cash on hand is taking that $2.5 million a day that it costs to operate the hospital and say, how many times can your cash reserves cover that $2.5 million? For us, it was at 62 days. It's over 90 today as we continue to recover from COVID. But it's really not an actual measure because it assumes that you will not receive another penny of income coming in. That if you had no other revenue coming in, which we obviously do, we're collecting about $2.5 million a day from Medicare and Medi-Cal and as we provide patient care services. But if you didn't have any more revenue coming in, we could, with our cash reserves, we could cover 62 days of our operating expenses. So it's kind of again, it's a measure of a hospital's liquidity. Our minimum threshold is we always have to be at or above 90 days. So pre-pandemic, we were pushing 170 days, which is why we had an A credit rating with Moody's. So it's going to take us a while to get back to that.
At the 90, what would our credit rating go to?
It still probably stays. So right now, unfortunately, we're called a Baa1, which unfortunately is one tick below investment grade. So in slang, our bonds are considered junk bonds. It doesn't affect us in terms of the interest rate that we're paying on those bonds because they're fixed. We would have probably an impossible ability to go out and issue more bonds because of that credit rating. I think investors would be skittish, even though our credit outlook was upgraded from negative to stable last year by Moody's. We're hoping to raise that Baa1. It'll take us a while to get back to the A3 rating. There's 4 levels between an A3 and a Baa1. So we'll probably gradually make our way back, but again, that's going to take time. But what it does is if you're a bondholder and you're holding a tax-exempt Cahuilla Health municipal bond, which is what they are, so the interest we pay on them is not taxable for federal and state purposes. But when our credit rating drops, the market value of those bonds drop. And so, as long as you hold them to maturity, you'll get your full principal back. But if you wanted to sell that bond in the open market before it matures, you'd probably have to sell it at a discount, something less than what you paid for it because our credit rating has dropped.
All right, more good news, right?
Yes.
Got more.
Yes. Okay. Prop 35, and thank you to all of you who voted for Proposition 35 on November 5th. So you've heard me talk about the Managed Care Organization tax, or MCO tax. That tax was in place for many, many years, but it expired at one point. The state used that tax that they collect every year from managed care plans. So like Anthem Blue Cross, Blue Shield, Cigna, Aetna, they would have to pay a tax on the premium revenue that they collected from employers and their subscribers. And that tax would go to the state, and the state would use 100% of it to balance the state's budget each year. So we were able, the California Hospital Association and the California Medical Association, which represents physicians in California, we were able to convince the legislature and the governor to reinstitute that managed care organization tax. And so the governor signed it into law back on April 1st, 2023. But it was set to expire on December 31st, 2026. But during that time period, they'd collect a little over $19 billion in managed care organization tax. The governor promised that he would use about half of that $19 billion to increase Medi-Cal reimbursement rates to doctors and hospitals. Now, he didn't sign that promise into law, so it was just a promise. And unfortunately, as the governor and the legislature got deeper and deeper into the fiscal 25 budget and found themselves facing a huge billion-dollar, I think at one time it was $78 billion budget deficit that they finally whittled down through a lot of different cuts and moving money around and so forth. The governor came to us hospitals and doctors and said, I know I promised that, but I need to take it all for the state budget. Very, very disheartening, disappointing for us. So the CMA and the CHA decided to put it to the voters as a ballot proposition, Proposition 35. And so it was on the November 5th ballot, and essentially it did a couple things. Number one, it made the MCO tax permanent. So it will not expire on December 31st, 2026. It is now a perpetual tax without any expiration date. Secondly, it signed into law that about 95% of that annual tax must go to doctors and hospitals and other healthcare entities to augment Medi-Cal reimbursement to providers. The governor can pull off a little bit, about 5% a year that he can put towards the state budget. But now the majority of it will be going to really what we had been hoping all along. So we will see the first increase in so the permanent tax and that 95% allocation to providers won't go into effect until January 1st, 2027. But the law also now is requiring the governor to use about $2 billion of the $19 billion that he is currently collecting that started on April 1, 23. About $2 billion of that will have to be used in calendar year 25 and 26 to increase to some level payments, Medi-Cal payments to doctors and hospitals. So it's a bump, but clearly not enough to support the thousands and thousands of hospitals and clinics, 400 hospitals, but thousands of doctors and clinics having to share all of that. We don't know exactly yet what it will mean to CWIA. But then beginning January 127, that annual allocation to hospitals will probably be in the $7 to $8 billion range. So that will be enormous. So we're very, very
And that's
excited
all
about that.
hospitals?
Yeah, so this is not, I could share one other bit of information if you had time. But this is for all 400 hospitals in California. Those that take Medi-Cal, and I've shared with you in the past that of the 58 counties in California, Tulare County has the single highest Medi-Cal enrollment of any county in the state. 62% of Tulare County residents are enrolled in the Medi-Cal program, which means they're living at or below the federal poverty level. We haven't had an increase in our inpatient Medi-Cal reimbursement rates in 14 years, and on the outpatient side, it's been 30 years. So a lot of this new managed care organization tax will really be earmarked for outpatient care. So the emergency department, outpatient surgery and procedures, endoscopic procedures, physical, occupational speech therapy, physician clinics and offices. So really outpatient, and it's good as more and more healthcare shifts from the inpatient side to the outpatient side. That's generally the area that's been the poorest reimbursed for providers.
So the first couple
Yes,
of
and
years,
so
we'll
that-
see a little bit.
Yes,
Well, a
yeah.
little bit. I mean, we're still talking
Yeah, we don't know
large
what that will
dollars, right?
translate to, but
And then 2027 is when,
when the
Yeah.
full amount, that 95% will kick in for providers. The last thing I will share, and I didn't have this as a question, but I shared it with the foundation yesterday. District hospitals. So there's 33 of us in California. Kauai Health is the largest district hospital. Of those 400 hospitals, we're organized as a healthcare district. So we're technically a governmental hospital, we're a public hospital, a publicly elected board. And so district hospitals can uniquely tax themselves and send that money to the state in the form of what's called an intergovernmental transfer. So us, a government hospital, sending money to the state, a governmental entity, who then recharacterizes that money we sent to them as now a Medi-Cal payment, and they give it back to Kauai as a supplemental Medi-Cal payment. They take a little off the top, sometimes as much as 20% for their administrative fee, but when they send it back to us, they then get to draw down on federal matching funds, because the Medi-Cal program is a shared program between the federal government and the state. Dollar for dollar, they match each other. So there's a program that we launched, district hospitals launched back on January 1, 2023, that raises about $200 million a year for those 33 district hospitals. So we've been working over the last year with the state and the federal government, bringing in actuaries and legal counsel. This is through the District Hospital Leadership Forum, which is an association of the 33 district hospitals. We have been working with the state and the feds to increase that annual amount from $200 million a year to $800 million a year. It has now been fully approved by the state. It now goes to the federal government, to CMS, which we are fully expecting their approval in the spring. And that increase will likely mean another $44 million a year in Medi-Cal funding for Kauai alone. Only district hospitals, so not St. Agnes or Valley Children's or Adventist Health. They do have their own programs, private nonprofit hospitals, but this is incredible what it means to this organization. And so many of the distressed hospital loan program recipients, more than half of them are district hospitals. And because district hospitals typically are located in more impoverished areas, they generally have a high Medi-Cal population that they're serving, like us. And so this will really just revolutionize what we're able to do.
and do you feel like you were maybe at the forefront of ringing that bell? Because, the letter to the governor and trying to bring attention to it, I mean, you were really kind of like the lone person sticking his neck out when all of that first...
You're really hurting my humility and my
Do you get what I'm saying, though? I mean, I
do.
can remember when a lot of people didn't want to speak out, and you said, we're going to speak out, and we sent thousands of letters, and they plopped them on the governor's desk, which he never responded to, I don't think. But I think it's brought a lot of attention to this. And so,
I think when I testified in Sacramento before the Senate Health Budget Subcommittee, I think that was eye-opening for a lot of them, and I really focused on public hospitals and district hospitals in particular. I'm currently the president of the District Hospital Leadership Forum, so I was very involved in that work with the state and soon to be CMS and getting that program increased. But yeah, I
Yeah.
appreciate that.
And
Deborah,
Shannon Grove and Mark Mertz and Vince.
yeah,
everybody,
exactly.
They all
we've
seem
been
to take up
meeting,
that mantle.
Yeah, and we had Congressman Jim Costa was here just a few months ago. New Congressman Vince Fong was here. He's been a big supporter of Kauai Health, and before him, Devin Mathis and definitely Shannon Grove. And I would talk to Mark Galley, who's the Secretary of Health and Human Services for Governor Newsom. He was calling me every week to check on us, and so I think a lot of people really came together to get the attention of the legislature and the governor.
Yeah. How busy is our emergency department right now?
Yeah, they don't like us to talk about it. If you ever walk through the ED, never say, wow, it seems kind of quiet in here. They will run you up the flagpole in a hurry. They're very superstitious and they think you're going to jinx it. But it has been kind of calm. I hope this isn't the calm before the storm, as they say. But really, over the 5 months of this fiscal year that started on July 1, we've been holding very, very steady at about 250 to 260 patients per day. That's the number of average visits, and it's only fluctuated by 2, 3, 4 patients every month. So the daily number of visits. When we're really just overwhelmed, we're hitting 300, sometimes pushing over the top of that. So we really, we're not seeing the respiratory surge yet that we typically would see, although we're still in the early part of December. It's generally when people start gathering indoors for Christmas and New Year's and so forth, that's when we really start seeing the flu spread, RSV. COVID is definitely still out there. Fortunately, it's a less severe strain that we're seeing, but we still are seeing a lot of patients that are testing positive for COVID, employees and doctors that are testing positive for COVID. But January and February is typically the peak of the respiratory season. So, but I'm glad to see that, it's kind of slowly coming, and maybe January and February will be moderate. We pay a lot of attention to the southern hemisphere of Earth. Down in Australia, New Zealand is where they first have their winter, and we monitor what kind of flu levels they're seeing down there. And what I've heard, it was relatively moderate, mild to moderate. Wasn't a real severe flu season. So
that's good.
Yeah,
that's good. You have some new leaders in the ED right now too.
Yes, and I'm Scott and Jeffrey, and their last names are escaping me right now, and we greatly appreciate. They just arrived within the last couple weeks. They're serving as an interim director and an interim manager. They don't want to be the permanent, but who knows if they have a phenomenal time and we can convince them to stay. Scott, our director, comes with just a great pedigree and reputation, and so we're excited to have him at the helm. So we're recruiting for, actually, when fully staffed, we will have 6 supervisors in the emergency department that are physically present during the day and the night. Obviously, we're 24/7 with the entire hospital, but having a nighttime presence is really important. We will have 2 to 3 ED managers and a director, and reporting up to Carrie Noweski, our chief nursing officer. We actually just had a kickoff meeting this morning with a consulting firm by the name of Chartis. It's a nationally renowned healthcare consulting firm. We've worked with them many times in the past, but we engaged them to actually come into the emergency department and help us become more efficient and our workflows to be more efficient. So people are spending less time in the waiting rooms, getting back to an exam room as quickly as possible, looking at staffing and how we're structured and the peak hours and so forth. We really want to significantly elevate the quality, the safety, and the experience of our patients and our families, certainly our staff and our physicians that work there. And so we're excited. They'll spend 2 to 3 months on site in the ED. Not just, generally consultants come in and they assess and they make recommendations and then they leave. And they leave it up to you to implement. This will be different. They actually will be there working shoulder to shoulder with us through the full implementation of these workflow changes and practices and policies to see that we've embedded them deeply and that they've been hardwired and we don't revert back to prior practices that are less efficient, less satisfying. So,
And how long will they be here?
so they will be focusing on the ED for about 2 to 3 months. So we had 3 nurses arrive this morning from Chartis. We will have a physician consultant that also will be joining them. We'll spend the next 2 weeks really kind of going through that gap analysis. And then obviously because of the holidays, they'll move off for a couple weeks. And then that first week of January after New Year's, they'll be here in full force at that time.
That's great. Thank you.
And we have all 73 beds in the ED are now open, including Zone 6, which is our 8-bed fast track to take care of less sick patients, stomach aches, earaches. The idea of getting you in and out as quickly as possible. Because of staffing challenges, we haven't been able to open that fast track unit, and so it's great to see it open. It's just been open for a couple weeks now, so hopefully folks are already starting to see a different experience.
That's awesome. So a community member asked what we at Kauai are doing to keep physicians here. He's heard that there is some exodus of some doctors, and he's concerned because he receives his care at a certain organization and he's heard the doctors are leaving. So what are we doing here at Kauai to try to keep physicians local?
Yeah, so we don't have to keep it a secret.
I'm
That's okay.
just-
So you're speaking about, excuse me, Visalia Medical Clinic and Adventist Health, who are in a medical foundation partnership that started back on April 30th of 2023. So there is turmoil there that we've all become aware of over the last several weeks. Adventist Health and Visalia Medical Clinic have made a decision that effective January 1, 2025, so just a few weeks away, that they are terminating their provider agreements with Key Medical Group. So Key Medical Group is a very large, probably the largest physician practice association, what's referred to as an IPA, Independent Practice Association or Physician Association. They have hundreds of physicians that are part of Key Medical Group practicing in Visalia and or Tulare County and Kings County. So they made a decision, Adventist Health, to terminate their provider agreements with Key Medical Group. So the first big impact that has is Key Medical Group and its physicians are the exclusive providers to the Humana Medicare Advantage population. So Visalia Medical Clinic has about 3,300 Humana Medicare Advantage patients. So effective January 1st, 2025, if a patient wants to remain with Visalia Medical Clinic and its physicians, it must disenroll from Humana and enroll with a different Medicare Advantage plan that contracts with Adventist Health. And so that's part of the turmoil is patients are trying to figure out, do I want to stay with Visalia Medical Clinic but give up my Humana plan, or I love my Humana plan, I don't want to leave it. And if that's the case, then you have to leave Visalia Medical Clinic and select a different Key Medical Group physician who is not part of Adventist Health or Visalia Medical Clinic. So if you have questions, definitely reach out to Key Medical Group. Their phone number is 1-800 539-4584. So 539-4584. And they can help you navigate through that. Key Medical Group also has a contract with Blue Shield for their HMO and PPO health plans. And it appears that Adventist Health and VMC is also terminating that agreement with Key Medical Group, which affects about 6,000 Blue Shield members that are part of Visalia Medical Clinic. However, it's a bit easier, I think, to stay with Visalia Medical Clinic, because what it will mean is that you as a Blue Shield patient will have to disenroll from Blue Shield Key Medical Group and enroll with Blue Shield Adventist Health. And so, it's a little less, significant than Humana or VMC. It's one or the other. In this case, it appears you could still stay with VMC and Adventist Health and Blue Shield, but you will have to move to a different Blue Shield plan. And I would suggest that you talk to your VMC physician or somebody in administration there. So,
Did that all need to be done though during open enrollment, which is
well,
October?
that's a good question, because it was my understanding that Medicare open enrollment closed on December 7th, started in October and closed December 7th. So I don't know what's that going to mean. If there's a change of this magnitude, where your provider, your physician terminates the Medicare Advantage program that you were enrolled in, does that reopen a window, or is there a special window for those that are affected in that way? And I don't know the answer to that question. Again, I would reach out to Key Medical Group. They certainly can answer those questions. Now, so that's what's going on at Visalia Medical Clinic. And I am aware of a number of physicians that are very upset, Visalia Medical Clinic physicians that are very upset about Adventist Health's decision to terminate these agreements and create this disruption. And I'm aware that some VMC physicians are seriously considering leaving Visalia Medical Clinic, either upset over this action that has been taken, or have just determined that working with Adventist Health has not turned out to be what they'd hoped it would be, and are looking to practice in a different practice setting. So we are not reaching out to VMC physicians, but I'm certainly answering the phone. Any VMC physician that wants to reach out to me or Mark Mertz or Ryan Gates, JC Palermo, we would welcome the opportunity to talk to those physicians about other practice opportunities. And they don't necessarily have to be with Kuya Health. You can certainly, like Dr. Sarmad Saeed, a very, very busy cardiologist that when VMC announced that they were discontinuing their relationship with Kuya and starting a new relationship with Adventist Health, Dr. Saeed did not want to be part of Adventist Health, and so he approached us and said, is there an opportunity for me to join Kuya Health or to stay with Kuya Health? And we were delighted to welcome Dr. Saeed. He is practicing now in our Tulare Cardiology Clinic. He's also practicing in our rural health clinics, and he's in our cardiology clinic over on the West Campus off of Acres Street. An excellent cardiologist, very, very busy. His practice is open to new patients as well. Our VMC physicians that are interested in a similar relationship with Kuya Health or other practice opportunities. Key Medical Associates, which was kind of an offshoot of Key Medical Group, is a formal medical group that employs or contracts with physicians in the community to practice in our community. And we would be delighted that the last thing we want to see happen is a physician to leave this community. We want them to stay in this community, and there are many other practice opportunities for them. And again, either at Kuya Health or KMA, or some want to go into private practice, go back and just be in solo practice. Dr. Roos, who was an ear, nose, and throat specialist, otolaryngologist, he was with Visalia Medical Clinic, decided to leave and go out on his own, and now has a thriving independent practice in the community. And we're fortunate that he stayed and wants to continue to practice here. At the same time, we also continue to actively recruit new physicians into our community. So I actually shared, I think it was at our Kauai Health Heritage Club dinner, kind of went back to my notes, and I shared with them that for the fiscal year that ended on June 30, 2024, so just this past summer, I shared with them that we recruited 18 new physicians into our community, 17 specialists and one primary care physician, as well as 10 new certified registered nurse anesthetists. So when you receive surgery and you're anesthetized, it's generally by an anesthesiologist or a CRNA, both highly skilled, competent providers of anesthesia services. We also we have 7 new providers that have joined us so far in this fiscal year, and we have offers out to 5 others, and they cut across multiple physician specialties. So pediatric hospitalists joining Valley Children's, critical care intensivists, psychiatry, dermatology, pulmonology. For the first time in I don't know how many years, we are going to have a dedicated outpatient pulmonologist coming to Visalia, joining Kauai Health. I think it's this summer. And you just think of the respiratory conditions that exist in our community. It is going to be wonderful. He's going to get very, very busy in a very short period of time. But general surgery, cardiothoracic surgery, Dr. Shelley Banzal just joined us, cardiothoracic surgeon, family medicine, vascular surgeon, and Dr. Ackery, a urologist from Florida, is joining us shortly. So a lot of good things, in the works, but obviously it would be great to see our medical community kind of calm down a bit. And we have enough anxiety in our lives to not have to worry about our doctor.
Right, and we know there's a huge physician shortage, even with bringing in 18, or however many you said. I believe the last physician report that JC gave to our community groups was, we are so low in a lot of them.
Well over 100.
Right.
Yeah, unfortunately, the Central Valley, the San Joaquin Valley, probably has the most severe physician shortage of any other area in California. When you look at the population per physician, it's one of the lowest. It's well below the statewide average, and then you go to some of the more metropolitan areas, we're about half of what their ratio of population to physicians is.
Right, and the accessibility, if you can't get in for 6 or 7 months,
Yes. Yep.
So speaking of physicians, let's jump to OBGYN, because this
Yes.
was one of the most hot topic buttons this year, because when OBGYN, Visalia OBGYN closed, or announced that they were closing, lots of women got a little skittish and nervous. So we brought on Holly
And
Quinn.
their husbands as well.
Yes,
Their men.
yes.
Yes.
Yes, and we brought Holly Quinn over to Kauai,
Yes.
and now we're hearing that she's almost full, or she is at capacity. So women who are wanting to be mothers or who are trying to get pregnant right now, the question was asked, who do they call? Where do they go?
Right. Yeah. Unfortunately, it is still, you said, the hottest topic. It remains a hot topic, and we're not even close to having solved the vacuum that Dr. Wiseman, Dr. Bosman, Dr. Lorianne Boken, Dr. Quinn was with Visalia OBGYN as well. We had been helping them recruit, unfortunately unsuccessfully, for about a year. J.C. Palermo was working closely with Dr. Wiseman, and we appreciate just how difficult it has been for them to recruit into their practice. With Dr. Lake, who retired, and so they've been struggling, which is really what led to their decision, and I'm sure it was an incredibly difficult decision to close the obstetrical part of their practice. So my understanding is Dr. Wiseman, and I'm not certain about Lorianne Boken, but I heard her as well, that they will no longer provide obstetrical care, but they will continue to practice in our community, providing gynecological care, like Andrea Boone does. But that certainly doesn't solve the obstetrical problem. So unfortunately, Dr. Bosman, if she hasn't already left, is headed to Tennessee. We were very fortunate that Dr. Holly Quinn did not leave our community. She had a job offer in hand from Adventist Health to join their Reedley clinic and hospital to practice there full time. When we heard word of that, we reached out to her and said, would you be willing to consider staying in Visalia and coming to work with Kuya Health? And fortunately, she said yes. And we were very accommodating. She's a new mom. She wanted, someday she'll get back to a full practice, but she wanted to work like a 0.9 or 0.8 full-time status. So she started out in our Exeter clinic. She now has moved to Visalia. So our 5-story medical office building, 202 West Willow, which is, right next to our helipad, next to the medical center. Dr. Holly Quinn is now on the 5th floor, providing maternity full OBGYN services. I'm happy to also report that certified nurse midwife, Rita Barron, today was her first day at Kuya Health. She was in my new employee orientation. Also a very, very busy midwife that delivered many, many babies for Visalia OBGYN. Worked side by side with Dr. Quinn. So she is rejoining Dr. Quinn, and so she is also working in that 5th floor location. Dr. Juan Sabagal and Dr. Carlos Rangel, who primarily work in our rural health clinics in Exeter and Lindsay, will also spend time now in Visalia seeing new patients, generally Visalia-based moms. So that's another option for new pregnant women or existing pregnant women. I don't know yet how many days a month that Dr. Sabagal and Rangel will be there. But at the same time, it is our number one recruitment priority right now. And they say in recruiting a lot, you can take the position of lag, follow, or lead. Lag means you're the least competitive from a compensation and benefit standpoint. Follow is you're just duplicating what everybody else is offering. Leading means you're differentiating yourself. You're putting yourself out in front. So we're trying to be a leader here, that we have the most attractive, competitive offers that are being made to candidates, obstetrical candidates out there. So we'll continue to recruit very heavily there, but I don't want to oversell because it is, again, very challenging, just like Dr. Wiseman's group experienced. But we also, more and more hospitals are contracting with companies or large obstetrical groups to form obstetrical hospitalist programs. It's one that we explored a number of years ago. I personally met with the leaders at a company called OB Hospitalists. Not all that clever, but they're based out of South Carolina. They are a national company, medical group, that provides OB hospitalist services throughout the country at hospitals. They come in, they staff the hospital 24/7 on site, delivering babies, supporting the L&D triage unit, the emergency department, the nursery, the NICU, wherever they are needed. Oftentimes, that when they go into a community, they're initially just delivering unassigned babies. So moms that didn't have prenatal care or a formal obstetrician. And so they will always deliver those babies. They also will deliver babies in an emergency where the patient's obstetrician can't make it in time. And so they will quickly step in and deliver that baby. But over time, a lot of community obstetricians start saying, getting up at 2, 3 in the morning, being on call all the time, isn't what it's all cracked up to be. And I feel very comfortable with this hospitalist group delivering my babies, which then allows me to spend more time in my clinic and see more patients to provide pre and postnatal care to. So you think about, a physician that's in their office and their patient goes into labor, they close the office and they run to the hospital and deliver that baby. And maybe it's a C-section that's going to take them time. And so being able to allow them to dedicate more time in their offices could expand the obstetrical availability as well. So we're approaching it from multiple angles, but it doesn't happen overnight. And so I wish I had, I'm definitely feeling better. We're moving in the right direction. Holly Quinn, Rita Barron staying here has been enormous to us. And I greatly appreciate Dr. Sabagal, Dr. Ronhell, providing backup and being part of that call group to support Dr. Quinn as she also supports them. So a lot more to come. It will continue to remain a very hot topic.
As women continue to have babies.
Yes.
I think we're 4,700 or 4,800 strong here. I
Yes.
think that's how many babies we
Yeah.
delivered last year. Wow. All right, we have a few more minutes, so let's talk about what social media is talking about and
Let me
our
guess.
lack of.
Our elevators. Yes.
I've used the stairs more in the past month than I have probably
I was going to
the
say,
whole
you
time.
look really fit. I mean, that's.
No, I'm huffing and puffing by the time I get to the fourth floor.
Yeah, I think we have about 14 elevators scattered throughout the acute medical center. The original Mineral King Wing that opened in 1969, and then the West expansion, the East expansion where labor and delivery, the Broderick Pavilion, the ED, the lab in the basement, and then the Asequia Wing, all have elevators. Certainly the elevators in the Asequia Wing, which opened in 2009, are the newest and most modern and most reliable. They rarely go down, although unfortunately sometimes we're a little hard on the elevators as we enter them with gurneys and equipment and so forth. It doesn't take much to damage the elevator or the electronic eye that senses, when somebody is entering the elevator so the doors don't close on them. Those are getting damaged all the time and having to be replaced. Where we're really experiencing, the cascade of downtime is primarily the Mineral King Wing and also the East expansion. And unfortunately, those elevators, some of which are the originals that were installed back in 1969, they wear out. You can just imagine the probably hundreds of thousands of trips those cars have made over the decades. And we keep them through service arrangements. So this is also, we have a phenomenal clinical engineering department that they're the ones that maintain all of our equipment. They do all the preventative maintenance. They repair, so many of our imaging equipment and surgical equipment. They're just incredibly talented people. But they're not allowed by state law to work on our elevators, and our maintenance department's not. You have to use one of only 2 certified elevator companies in California to repair your elevators. And so every hospital in California is having to use this same company. And so we're at their mercy, sometimes taking weeks, if not months, to get them on site to repair an elevator. So that's why it seems like our elevators are down for long periods of time, is because we're either waiting our turn for that repair company, or our elevators are so old they don't make the parts anymore. They're not available. There is no supplier. And so we actually have to borrow parts off our other elevators so that those that are less used, we can take the parts off them, which renders them inoperable, but we put that part on an elevator that is used much more regularly to get that elevator back into service. Or those parts have to be engineered and fabricated for us from scratch. So the manufacturer is no longer making those parts, but we engage with a company that can essentially replicate those parts. But they have to make them, and they're making them custom for us, and that takes time. So, but there's good news in sight. So our current year budget that we're in right now, we included in our capital budget 3 brand new elevators to replace our existing ones at a cost of about $1.5 million each. So we will be looking to replace 3 new ones, but again, we're at the mercy of the manufacturer and the installer to put those in place. So I don't know exactly when the new elevators will become operational. But as I was thinking about this question, I can't not also think about the 47 million in FEMA funds. And while we want to discipline ourselves, elevators, and I sincerely apologize to our patients, our families, visitors, our employees, our vendors, our physicians for the significant inconvenience that this has caused. Long waits to get up to your loved one's floor or to get down the elevator. And we are very sensitive to that. And so, I would like to talk to our finance committee, talk to our board. Should we seriously consider accelerating our replacement of more elevators by using some of these FEMA funds? So,
So we're working on it. We're working on it.
Definitely.
We understand. We know it's an issue.
Yes.
Okay, Health Grades, top U.S. hospital for spinal surgery.
Yeah, actually, a couple of recent awards. So you've heard me talk about Health Grades in the past. It's a national company that collects millions and millions of pieces of data on physicians and hospitals and other healthcare providers. They analyze and evaluate and grade hospitals on a multitude of different services with respect to avoidance of mortality or complication rates and outcomes, quality and safety, and so forth. And we're delighted to share with you that Healthgrades just announced that Cahuilla Health was named one of the top hospitals in the country for providing spine surgery to our patients. So Dr. Daniels, Dr. Feng, orthopedic surgeons that provide spine surgery, our neurosurgeons, Dr. Williams and Dr. Chen, Dr. O, and a number of them have really elevated the quality and the reputation of our spine surgery program. There were 21 hospitals in California out of 400 that received this designation, and Cahuilla was one of those 21. So making that recognition even a little bit more important. And then the last one today, so breaking news, U.S. News and World Report just released its rankings of the top best hospitals for maternity care. Speaking of which, talking about OB and our almost 4,800 births. So Cahuilla Health was named one of the high-performing maternity programs in the country. Again, just really a testament to our incredible staff in labor and delivery, our NICU, mother-baby, our obstetricians, whether with Family Healthcare Network or our rural health clinics or Altura, one of our FQHCs in our community. Just some phenomenal providers and staff that really come together to provide this excellent care. And U.S. News and World Report stated that high-performing hospitals showcase exceptional care for expectant parents, demonstrating significantly lower C-section rates and severe unexpected newborn complications compared to hospitals not recognized by U.S. News. So just my hat's off to that incredible team that provides exceptional maternal care here.
Yeah, that's great. That's great. All right, our time is up.
See how easily I can fill an
You
hour?
can,
That's-
you can. And you have 2 weeks to get your wife a nice Christmas gift. And this year's going to be exciting because you've got grandbabies.
Yes.
So that always makes Christmas really exciting. So, Gary, why
does.
don't you end it?
Yeah, this will be our last telecast of the 2024 calendar year, and before last telecast before Christmas and New Year's. So I just want to wish everybody just a wonderful and blessed holiday season, whether you're celebrating Christmas or New Year's or any of the celebrations, the holidays that we honor this time of year. And I hope you have time to have spend with family and friends. And I know Deborah and I and David and Daniel, we have so much to be grateful for. And so this time of year certainly is a time to just reflect on our blessings and all the wonderful positive things in our lives, despite all the challenges that exist across our society. So just want to say thank you again for joining us every month for this telecast, whether you're watching it live or we'll watch it later on the recorded version. Thanks for tuning in, and we'll see you next year.